Good evening, everybody. Um, Good evening and welcome. Karen, just to confirm, can you hear me clearly? Can you see me?
Can hear you and see you. Please go ahead.
All right. Good evening, colleagues. Professor Jill Watermeyer is coordinating this session. She's having some issues with her laptop and connectivity. She has asked that we do continue and she'll join as soon as she can. Jill has seen the presentation, so she's fully aware as to what I will be presenting this evening. So my name is Nasief van der Schyff. I'm a fellow at Groote Hospital and at UCT. And I work in the IBD clinic as well with Professor Hortemeyer and Professor Shady and colleagues. And I've been allocated the topic of peri-anal disease in peri-anal disease in Crohn's. Or peri-anal Crohn's disease. I'm gonna share my slide. Karen, if you can please confirm if you're able to see my slide.
Not as yet. I'll tell you when it pops up. Nothing yet, Nasief.
All right, not yet. Perhaps I should share my screen. That's a good way to start. All right, so let
I can
me.
see it coming up. Yes, you can just put it into presentation mode.
All right, excellent, and put it into presenter view. All right,
There you
can you
go.
see that?
Thank you.
All right,
Yes,
thank
perfect.
you, thank you very much, Karen, and once again, colleagues, welcome to this Monday evening fellows presentation. As I said, Professor Hortemeyer will be joining us for this ECHO presentation. Once again, a huge thank you to Project ECHO for allowing us and enabling us to have this interactive educational forum. And as I've indicated, I will be presenting the topic of peri-anal Crohn's disease. So over the course of the next 40, 50 minutes, this will be the outline of my presentation. I'll be dealing with the epidemiology, the peri-anal anatomy, the pathogenesis, the classification, how we assess patients, how we evaluate patients, and then ultimately the management of these patients. So if you look at the epidemiology of peri-anal Crohn's disease, peri-anal disease is common in the context of Crohn's disease. Its incidence is 18 to 43% of all patients with Crohn's disease. But importantly, fistulizing Crohn's disease has a 25% incidence. And for all the other peri-anal manifestations account for 10% of peri-anal disease in patients with Crohn's disease. Important to note that peri-anal Crohn's disease precedes luminal disease in 45% of patients, with a median time of 4.5 years from the time of having peri-anal disease to then developing luminal disease. But it's important to note that 5% of patients can have isolated peri-anal Crohn's disease with no luminal involvement at any point in time. And that in that particular subset of patients, it can be a very difficult diagnosis to make. This is a very difficult condition to treat and to manage, and it is associated with significant morbidity and decreased quality of life. And the whole concept of refractory, non-healing peri-anal disease is common, is debilitated, and difficult to treat, and unfortunately, it is quite common. So peri-anal Crohn's disease is associated with an increased risk of developing exterior intestinal manifestations of Crohn's disease. There's a 5 times higher chance of developing luminal fistula, and these patients have there's a higher incidence of requiring surgery. The risk is doubled. So if you look at the risk factors for peri-anal Crohn's disease, certainly the commonest risk factor is having distal colonic disease, especially proctitis, and that is about 92%. And in actual fact, there's only 12% of patients that have idle disease and isolated as well as peri-anal disease. Other risk factors include being male, the longer you have peri-anal disease. If patients have Crohn's disease, luminal disease, and have extraintestinal manifestations, that they have a higher risk of developing peri-anal disease. Also, the usage of steroids is associated with a higher risk. And on the converse of that is that if we use steroid-sparing agents, it is associated with a lower risk of developing peri-anal Crohn's disease. Now, importantly, this concept of peri-anal fistula, it is a severe phenotype of Crohn's disease. It may present before or after luminal disease, and it is in 10 to 30% of cases, it precedes luminal disease. Peri-anal fistulas is associated with a higher risk of hospitalization, increased cost, healthcare costs, greater requirements of immunosuppressives. About 2/3 of patients require surgery, and also a higher risk of complications. And this explains why this is such an important condition to know. In terms of the pathogenesis, it is poorly understood. The current thought process is that there is a genetic predisposition that results in an aberrant immune response to gut microbiomes and ultimately causing intestinal inflammation. And in patients, biopsies taken from patients with peri-anal Crohn's disease, there's increased levels of TNF-alpha, transforming growth factor beta, as well as IL-13, and this ultimately results in mesenchymal cell transition and cell invasion. So what actually happens is that when a patient has a peri-anal abscess, there is spontaneous drainage or penetration into adjacent organs or skin, and most commonly it is a peri-anal skin. But important to note is that other structures may also be involved, including the groin, vagina, and the bladder. And once this abscess is dissolved, we left with this residual fistula tract, and disease fistula tracts that place the patient at risk of recurrent peri-anal abscess. It's important to note that in patients that do not have Crohn's disease, and other fistulas tend to originate from infected anal cryptoglandular complex, which is a slightly different area within the rectum. In terms of the incidence of Crohn's disease, as I said, there's a up to 30 to 40% of developing fistula, and the longer that we have that the patient has Crohn's disease, that risk goes up. And this is a study from the 90s. But interestingly, the study that was repeated about a few years back in data published from 2018 shows that in actual fact, the incidence of peri-anal Crohn's disease is actually coming down, as we can see from the graph on the right. And that is due to the early usage of biologics. If you look at of peri-anal fistula, of fistulas in Crohn's disease, in 54% of cases, it is peri-anal involvement. But also, as I've indicated previously, there can be involvement between the gut enteroenteric fistula, it can also be a rectovaginal fistula, and other accounts for 13%. In terms of the long-term fistula outcomes, unfortunately, as we're sitting here, it is still very disappointing. And this paper published in 2014, data from Netherlands, where they looked at a retrospective study from Leiden, looking at 232 patients over a 10-year follow-up. 78% of patients had complex fistulas, I'll speak about now. Long-term healing in these patients with complex fistula was only seen in 37% of patients, and roughly over 50% of patients required surgery. And even as we speak now, after 22, 25 years of biologic usage, the apoplectomy rate in the recent Mayo cohort actually still remains unchanged at 19%. So just to remind us of the anal anatomy and the rectum, this particular slide just shows us the rectum, the upper, middle, and lower third of the rectum. And as we zoom in, looking at the peri-anal anatomy, this is what we need to know and understand. And the most important part, I would say, is understanding the sphincter. So I'm not sure if you can see my pointer, but you need to know the external anal sphincter on the outside, and just middle to that, the internal anal sphincter. That's important because a lot of the classifications depend, and the outcome depends in terms of sphincter involvement. We can also see that the dentate line, which is the transition area between the columnar and the squamous epithelium, and that's an important area. And I'll just show that. I'll bring up the slide a bit later on. But one of the imaging modalities that we use is endoscopic ultrasound, where there's endoanal or endorectal ultrasound, and we can see there's a cross-sectional view where we can see the internal sphincter on this side over here, as well as the internal anal sphincter. So when we have patients with peri-anal disease and setting of Crohn's, how should we evaluate this patient? And as with any other patient, it starts with a history. So this is the typical history that we would encounter in our clinic. The commonest symptom certainly is perianal pain. And perianal pain may occur at rest, with movement, but also with a bowel movement as well. Perianal discharge is a very debilitating symptom. That's certainly common, especially if people have draining fistulas. But an important question to ask is, ask your patient, when they pass urine, are they passing stool or passing gas when they urinate, that could indicate a possible rectovaginal fistula. One of the most distressing symptoms of patients is the risk of developing fecal incontinence. But also, when we evaluate patients, we ask for a past history of any previous history of perianal fistulas. And when patients have a perianal abscess that's untreated, they can certainly develop signs of SIRS response and systemic infection. But typically, as I've indicated, you may have luminal involvement. So as we're asking questions around the perianal anatomy and symptoms related to that, we also need to remind ourselves of assessing the luminal Crohn's disease. The patient may have diarrhea, they may have urgency, they may have pure bleeding. If patient is known to have Crohn's disease, it's important to know that and for how long it's been there. If patient is not known to have Crohn's disease, a family history of IBD. And as I've indicated, if patients have extraintestinal manifestations of IBD, that is that then at increased risk of developing perianal disease. So this slide from Up to Date beautifully illustrates the common manifestation of perianal Crohn's disease, where patients can be seen with an abscess, they can be seen with a perianal ulcer, they can be seen with skin tags, they can have a fissure, or importantly, they can have a fistula after the abscess have been drained. Other manifestations include increased incidence of hemorrhoids, anal strictures, as well as anal cancer. So I'm going to show you a few pictures that we typically see in the IBD clinic. Here's a picture of a perianal abscess that appears as erythematous structural bowels with surrounding erythema. And importantly, in patients with perianal disease, perianal Crohn's disease, there's a higher incidence of skin tags. And skin tags is a very close correlation with future development of perianal disease. And whilst it can be small to the skin tags, we typically have also these very big skin tags that is termed an elephant skin tags. And here we can see this picture from Up to Date, also showing this typical elephant ear appearance of the skin tags. So while skin tags are very common in a general population, and increase in Crohn's, we get pretty much this exaggerated form of skin tags seen in patients with perianal Crohn's disease. Perianal fissures are important, where it may just present with a simple fissure, where it looks almost like this sort of this paper cut, and as with any other fissure. But in patients with perianal fissures in setting of Crohn's, there may be some chronicity to it, as showed in the slide on the right. And we can see typically patients with chronic anal fissures seen in Crohn's disease, it tends to be predominantly in the posterior midline, and this typical appearance of this raised edges with this fibrotic appearance pretty much distinguish it from, an acute anal fissure as I'd shown in my previous slide. Also, there's a higher incidence of perianal ulcers, and as I've shown in this particular slide, the anal ulcer just being above the anus. And these ulcers are typically non-healing, and they may have chronic drainage associated with them. Now we can begin to understand why this is such a distressing condition for our patients. Also, there's a hemorrhoids or increase in patients with perianal Crohn's disease. We see here on the picture on our left, hemorrhoids seen on retroflexion when we do a colonoscopy, but also the hemorrhoids may also at times become thrombosed, and that requires immediate intervention. But certainly, as I've indicated earlier, perianal fistula tends to be almost the hallmark of patients with Crohn's disease and perianal disease, and it may present with essentially multiple openings, and patients may present in the appearance may be quite benign looking, as we see here on our left hand side, where there's an external opening of the skin, but also if you haven't seen it before, patients may have setons that have been placed by the surgeons, and I'll speak about that shortly. This picture over here beautifully illustrates that patient may have multiple openings from the fistula, but typically also with the skin tags. So this combination of fistula openings with skin tags is very typical for patients with Crohn's disease. This typical appearance of a wide mouth anal fistula seen here in the arrow on the white is typically seen in patients with Crohn's disease. If you ever encountered this severe, and I'm not sure the picture reflects very well, but this combination of patients having a peri-anal fistula with proctitis, that combination is pathognomonic for Crohn's disease, right? So the luminal disease or the proctitis with a fistula, and it's particularly relevant in patients that are not diagnosed to have a Crohn's disease. Sadly, this is the reality for many of our patients, having multiple fistulas, but also the presence of multiple cetons that have been placed. So how do we classify these? How do we classify patients with peri-anal fistulas? So the POX classification is very well known and very well used, particularly by the colorectal surgeons. This POX classification issue came out in the 90s. It is based upon the anatomical position of the fistula relative to the internal and external sphincters. And there are 4 types of fistulas based upon, how this fistula relates to the sphincters, the internal and external sphincters. And as I've indicated, it's mainly used by the surgeons, but we need to know about it. There's just a lateral appearance of a transsphincteric fistula that traverses both the internal and external fistula. Certainly the most widely used classification amongst gastroenterologists worldwide was released by the American Gastroenterology Association in 2003, where there's differentiation between simple fistula as well as complex fistula, right? The simple fistula certainly is actually very uncommon, and I'll talk of that in the next slide. But this classification aims to define the fistula based upon the fistula tract anatomy, the number of external openings, the presence of peri-anal abscess, and the presence of proctitis. And critically, differentiating between simple and complex is if there is sphincter involvement. So we can see here, so the simple fistula is pretty much as a very low fistula. It's a simple fistula. Patients often do not have severe sepsis. And we see it very infrequently, certainly for the majority of our patients that we encounter at hospital are patients that are having complex fistula that is quite high, often above the dentate line, where the patients have multiple external openings with associated peri-anal abscess, as well as, and this fistula may involve, multiple areas involving the skin, the vagina, as well as other parts of the GI tract. So after we've had our clinical assessment, we've now taken history, we've now examined the patients with us in our room. What do we do next, right? Our next step pretty much is aimed at identifying 2 things. Number 1, defining that fistula anatomy, right? As well as excluding, importantly, peri-anal abscess or just general sepsis in the perineal area. And we have 3 options available to us. The usual next step is doing an examination under anesthesia, right? But also, imaging is important. And imaging takes the form of either an MRI pelvis, which I'll speak about shortly, or an endoscopic ultrasound that is referred to either as endoanal or endorectal ultrasound. So if you examine the patient, there is a peri-anal abscess, the immediate next steps is referral of that patient to experienced surgeons, ideally a colorectal surgeon, for an examination under anesthesia. So while it's important to image the patient, imaging should not delay EUA if there is clinical evidence of peri-anal sepsis that requires immediate drainage. And importantly, the key to successful management is to establish adequate drainage of all abscess and to control fistula healing. And imaging plays a very important role in providing a virtual roadmap to define the peri-anal anatomy. So interesting, I came across this in my the presentation, in my preparation for today's talk, that our normal digital rectal examination done in experienced hands only has an accuracy of 62%. And And it's difficult because of the large amount of scarring and induration that is present in patients often that had peri-anal cones for a while. So pretty much a pure rectal exam is not good enough. An EOA is better, it's accurate, but still it's not a perfect test. There's still about a 10% hit-miss ratio. So the EUA, we've now referred the patient to the surgeon, right? They're performing an examination under anesthesia. What are they looking for? Number one is they want to assess the anatomy of the peri-anal of peri-anal fistulizing disease to identify the number of fistular tracts there are. Is the anal canal involvement? Importantly, is there a stricture within the anal canal? But also assess for the presence of peri-anal abscess. And generally, if there's an abscess in the context of this patient, there's usually, most cases, there's a fistula present. But often the fistula can only be identified afterwards once you have drained that peri-anal abscess. So the initial surgical management includes number one, incision and drainage of the peri-anal abscess. Number two, insertion of setons that I'll speak about shortly. Or if you are lucky enough to have a simple fistula, doing what is called a fistulotomy. So what happens in a fistulotomy? A fistulotomy is only indicated very seldomly for patients that have a simple fistula, pretty much referred to as your fistula anal, and there's no evidence of proctitis. Certainly, the risk of doing a fistulotomy in setting of proctitis is the risk of a non-healing of a non-healing scar. And what the surgeon does is that it opens the fistula tract along its length with the purpose really of obliterating the epithelialized tract. And this is in the right setting. This is quite an effective procedure to do with a healing of 80% healing of this fistula. But unfortunately, there is about a 15% recurrence. The biggest risk of a fistulotomy, as you can imagine, the opening the tract is the risk of incontinence. And that is if there's sphincter involvement. And that may just be that perhaps it wasn't properly assessed at the start. And the risk of incontinence is raised if the patient has a short anal canal, if there is involvement of the external sphincter that was perhaps misassessed at the start, or if there's presence of persistent diarrhea that may indicate the patient by having luminal disease. So the patient's been referred to the surgeon. The surgeon has done an EUA, but what happens sometimes is that the surgeon's done an EUA, and if the surgeon misses a fistula while performing an EUA, there is a 50% chance that a new fistula will form. And this study done, it's quite dated now in 2002, showed that an MRI done in this context, where the surgeon has missed it, an MRI may pick up a fistula that was not detected almost every time. So an MRI scan, so when the surgeon misses it, MRI was found to correctly and most times predict a fistula, and also if it was missed, a fistula recurrence. And once again, highlighting the importance of imaging in this context. An EUA where the person of sedence done before treatment with infliximab was shown to be beneficial in this 2003 study, where an examination under anesthesia before infliximab was associated with a superior response to treatments and a longer duration of fistula recurrence where the patient didn't have the EUA. Hence, once again, highlighting the importance of doing an examination under anesthesia. So we've seen setons, we've heard of setons. I didn't know too much of setons before I've done gastroenterology, so I had to educate myself. And setons is an important component of the management of complex fistulas, and it's inserted by the surgeons often at the time of draining an abscess, and it serves the purpose of controlling peri-anal abscess or peri-anal sepsis. And setons, they decrease the incidence of recurrent abscess formation, as well as decrease the amount of new fistula tracts being formed. And essentially, they improve the efficacy of healing. As we can see in this graph over here, there's abscess, and we can see how the placement of these setons by the surgeons can help to promote drainage of that. And setons are generally quite well tolerated by patients. You know, they are generally easy to insert under when an EUA is done. And importantly, Cetone should not be used in isolation, right? If you only use cetones and give antibiotics and do nothing else, there's a significant risk of reintervention rates of sepsis coming back and patients not being properly managed. So cetones cannot be used in isolation. Importantly, cetones should be seen in terms of dual usage with medical therapy and what that means, but that is early initiation of biologics. So this study that was published 2017 by David Schwartz, who's one of the pioneers in the field of peri-anal Crohn's disease, demonstrated the impact of cetone placement in reducing the number of hospitalization and associated cost. And as you can see here, SBP stands for cetone before biologic. And we can see that once the cetone was in place, higher chance and with correct uses of antibiotics and early use of antibiotics and early use of a biologic treatment, patients did better than if they never had a cetone placed. So when to remove the cetones? It's a difficult decision and it's not really fully resolved in the literature to remove it early, to remove it late. And pretty much at Groote Hospital, we still have patients with cetones in for years. But generally, according to the literature, it should be a collaborative discussion between the gastroenterologist and the colorectal surgeon and guided by the usage of imaging. And in order for this to happen, now we now want to take out the cetones because as long as cetones there, essentially that fistula tract will never close. But in order for this to happen, that local infection has to be fully treated. All abscesses have to be adequately drained. Patients should have had follow-up imaging to show that there's improvement in inflammation and sepsis. Patients generally well established on biologics and immunomodulated therapy. There's good biologic drug levels shown on therapeutic drug monitoring, and the proctitis, if it's present, has been well controlled. So you can see it's not a simple matter of just removing the cetones, and that's one of the reasons that many patients have cetones in for a long time. All these factors have to be considered before the cetones can be removed. So just a little bit in the next few slides in terms of the imaging modalities that we use. So endoscopic ultrasound is an important imaging modality, and unfortunately still not widely available, but it is ideally used when the peri-anal pathology is adjacent to the anal canal. And it can be used in real time, done at the time of EUS intraoperatively, though it is invasive. But in the right hands and the right setting, it can accurately identify anorectal strictures. But as you can imagine, if stitches are there, it may be difficult to insert a probe because of the narrowing of the anal canal. As I've shown earlier, this is how it looks like if you do an EUS showing the presence of the sphincter. And what you may see is essentially, as the shown over here with the arrow in yellow, there may be air in the fistula tract that is shown on the EUS. And this is one of the studies that I looked at and showing that initially you have an active fistula, right? As it's been treated, there may be air in the cetone, and eventually you may have scar tissue that is formed, and this is at week 30. This retrospective study highlighted the benefit of EUS. It was published in 2005, where they had 21 patients with peri-anal Crohn's disease with symptomatic complex fistulas who underwent serial EUS over time, and all patients had a baseline EUS. They were on maximum medical therapy, and using EUS to guide therapy and pick up, sepsis and managing sepsis inflammation adequately has been shown to be beneficial. And highlighted in this slide where this and that particular retrospective study gave rise to two prospective studies. The first one was published in 2008, where we had patients, all patients had received that sepsis controlled with drainage and cetones. They were given antibiotics. They were given a biologic. The difference was the one group had regular EUS and the other group never had regular EUS. So everyone had to start and at the end. And what the studies pretty much showed was that the probability of having draining peri-anal drainage was less in patients that had EUS. The second prospective study was this one that was identified very similar, showing that EUS done frequently over time. The study was done over a period of 54 weeks. patients had EOS at 22 and 38 weeks. It was shown with the improved healing of the peri-anal fistula at 1 year. In terms of what's available for us, especially at Tertiary Hospital, is MRI scan of the pelvis. And in comparison to surgery and endoscopy, MRI of the pelvis has a 76% sensitivity and specificity for fistula detection. For abscess detection, it has a 86 to 100% sensitivity and 93 to 100% sensitivity. It is the gold standard of imaging. It's non-invasive. MRIs are generally preferred to CT scans because of the risk of radiation that serial CT scans will have. And MRI scan still gives us the most comprehensive, of all the diagnostic modality. And when they do an MRI scan on T2 weighted imaging, we are able to see fluid in the fistula tract and any abscess that can be identified at high skin level. And once we have contrast with gadolinium, we can see areas of neovascularization that's indicative of fistula healing. So you can understand how an MRI may be useful. Just to show you how it looks like. So I've shown you the earlier slides where we show the peri-anal anatomy. So we can see the sphincters, the internal sphincter shown on the MRI scan. But also on T2 weighted imaging, you can identify quite accurately peri-anal fistulas on MRI scan. So in terms of standardizing how radiologists interprets MRI scan, they have come up with this what is called the modified Van Ascher index. And the modified Van Ascher MRI score, it's a standardized assessment of peri-anal fistulas to identify the severity and the response to treatment. And they look at various aspects of the peri-anal canal, assessing the fistula tract, its complexity, the fistula location, involvement of the rectal wall and abscess. But important to note is that often MRI, the picture in the MRI, it lags the clinical response. And roughly a third of the patients that we treat, the MRI may not improve. And if anything, the MRI improvement may only be seen at 6 to 12 months later. That's important to understand. MRI similar to ES has been shown to improve healing over time by doing serial MRIs. And in this particular study, the serial MRIs showed in the short term to have clinical improvement in 55% of patients. Interestingly, in the mid to long term, there wasn't a benefit shown. So now we've spoken about doing an EUS, spoken about MRI, and we've spoken about an EUA. All these three methods have been shown in this study. It's now quite old to be effective. For EUS, it had a 91% diagnostic accuracy. In EUS, 91% accuracy, MRI 87%. But importantly, if you were to combine the two, in other words, the patient has the EUA, you examine the patient, they have the EUA, and that's followed up by an MRI scan that has a 100% diagnostic accuracy for detecting peri-anal fistulas. Once we've done that, it's important then to follow this up with a colonoscopy to assess luminal disease, the degree of proctitis. On a colonoscopy, we can see external fistula opening that's usually visible on the skin, but also endoscopically, we can see internal fistulas. For new patients, there is a differential diagnosis that we need to consider. If the patient not labeled to have peri-anal Crohn's disease, it can be hard, especially if there's no luminal disease. So this slide indicates, whether we should consider patients for STDs, for hidradenitis suppurativa, for TB, actinomycosis, as well as the hematological malignancies. So it can be a difficult diagnosis to make initially. Do we do biopsies? Well, the issue with peri-anal biopsies is that it has a low sensitivity and specificity for Crohn's disease. And roughly one-third of granulomas, one-third of biopsies shows the presence of granulomas. The major role of biopsies is to exclude a malignancy. Once the goals of managing our patients is, number one, is that looking at what are the goals of therapy. From what therapies will we prioritize? What are our preferences, and having a multidisciplinary approach. So in terms of goals of therapy, complete fistula closure is the primary therapeutic goal for most patients. However, because this is such a difficult condition to control and many patients have this problem for years, it may not be possible to have complete fistula closure. In this context, symptomatic improvement to improve quality of life is very important. And symptomatic improvement to decrease rectal pain, to decrease drainage, that could be the next outcome for patients where it's very difficult to treat. In terms of how we follow up our therapies, number one would be to eradicate infections. Number two, as I've said, assess luminal disease and as well as the fistula tracts. And in terms of, the literature hasn't clearly defined, what's the preferred. It's pretty much patient dependent. But important factors that influence our decision making is, number one, the severity of the clinical manifestations, then the anatomic complexity of the fistulas, how the patients cope in the quality of their life, the risk of adverse events from the surgery or from our treatments, the presence of luminal disease, what patients prefer, as well as how they've responded to what we've done. Clearly, in this context, a multidisciplinary approach is required with input from your gastroenterologist, the colorectal surgeon, the radiologist, and the histopathologist, as you often do at our MDT meetings. The medical therapy available listed on this slide, with the antibiotics, the immunosuppressives, biologic agents, and to consider novel therapies that are available. Antibiotics, the standard therapy that we have is metronidazole and ciprofloxacin. That's commonly used, either separate in combination. Pretty much you won't use cipro for more than 2 weeks, but it's been published to have metronidazole for 1 to 2 months. Is often what we do. And antibiotics are useful just pretty much for the short-term benefit of fistula drainage. The data is limited from the 90s. It's very limited data. If patients have simple fistulas, often will give antibiotics just for the simple fistula, which is rare, but more often than not, we are going to give patients antibiotics and having combination therapies with anti-TNF and thiopurine. Topical antibiotics is ineffective. In terms of thiopurines, that was, used to be the hallmark of our therapy before we had biologics. We are still using azathioprine and 6-mercaptopurine. Data is limited. So the biggest data was from the 90s from a meta-analysis series where there was 5 studies and aza and 6-mercaptopurine was better than a placebo. And at best, the impact of thiopurines is it has a modest impact on fistula response. We now know that combining antibiotics with thiopurine is better than antibiotics alone. But more often than not, azathioprine is used as an adjunct to anti-TNF more for its immunogenicity. Moving on to our mainstay of treatment being infliximab. So infliximab is currently the mainstay medical therapy for peri-anal Crohn's disease. It is the only one that has been thus far been demonstrated in it's the only one that has demonstrated efficacy in a randomized control trial. The landmark studies came from the late 90s as well as 2004, where infliximab outperformed placebo for induction and maintenance fistula healing. The induction studies demonstrated fistula healing where 68% of patients that received 5 milligrams per kilogram of infliximab benefited. Interestingly, the higher dose wasn't shown to be as effective. The follow-up study that was published in NEJM in 2004, the maintenance studies using 5 milligrams per kilogram every 8 weeks demonstrated an extended time to recurrence to more than 40 weeks, as well as remission in only 36% of patients for 54 weeks. This was the hallmark study in 1998, showing that you can see 68% of patients benefited with induction infliximab at 5 milligrams per kilogram. The follow-up maintenance study that I'm showing here showed in 2004 from the NEJM, showing that certainly 5 milligrams per kilogram used every 8 weeks is beneficial. More recently, especially patients that we cannot use infliximab, adalimumab is an alternative. There's still no randomized control trial to evaluate adalimumab. The CHOM trial was a regional trial that had demonstrated adalimumab, where it showed a higher rate of fistula closure, 33% compared to placebo at week 56. And the trial that followed on the CHOM trial was the ADAFI trial. And this trial, actually, they looked at combining adalimumab with the antibiotic. Antibiotic chosen was ciprofloxacin, was better than adalimumab alone. You can imagine, we know why, because of managing sepsis. But importantly, once antibiotics were stopped, the outcome was the same for the arm that only had adalimumab. This was the trial of the CHARM trial. I'm just going to skip this. But importantly, higher trough levels was associated with better outcomes in patients with peri-anal cone disease. This study that was published a few years back, showing that trough levels of pretty much between 15 and 20, 15 to 20 was associated with a superior outcome than our usual trough levels between 7 and 10. So 15 to 20. So the important point there is we may need higher doses of your infliximab levels to have higher trough levels to improve fistula healing in patients with peri-anal cone disease. When do we start anti-TNFs? We've now treated the infection. When do we start it? The current recommendation is that early use of anti-TNF in newly diagnosed cone disease has been associated with a 59% risk reduction in developing peri-anal cone disease. So early usage of biologics lowers the risk of developing peri-anal fistulas. However, in general practice, there is a delay in starting anti-TNFs, and the median time is about 6 months. So if diagnosed with Crohn's, and there's about a 6-month period of starting the anti-TNF, and that generally is due to peri-anal sepsis. And the concern really is that if I start the anti-TNF, is it going to make the sepsis worse? The current recommendations from America and from UK and from Europe is that the early initiation of anti-TNF should be considered following ceton insertion with concomitant use of antibiotics, and it is associated with a lower risk of reintervention compared to chronic fistula, and as well as combining anti-TNF with a thiopurine. I'm going to skip this trial, but this trial just had shown that, here in this trial, published in 2019, using early or late, there wasn't actually a difference in this trial. But there were various flaws with this trial. The recommendation is still that we should be looking to start, where possible, anti-TNF sooner rather than later. In terms of other biologics that we have available, there's limited data from istakinumab. We're currently awaiting the outcome of a randomized control trial. But istakinumab has been shown to be beneficial on the retrospective review using post-hoc analysis with a benefit in 20 to 30% of patients. What about vedolizumab? So this trial was published last year in 2022 from what is called the Enterprise study. And the Enterprise study, they had given vedolizumab for patients pretty much that was, patients that was optimally managed. They had an inadequate response or loss of response to anti-TNF. There were 34 patients, and pooled data had shown that vedolizumab was beneficial. For 46% of patients, there was more than 50% reduction in damage of fistula at week 22 and 30, and in 42% of patients, there was 100% fistula closure at week 30. So certainly vedolizumab in patients where we cannot use the anti-TNF has now been shown to be beneficial. The latest novel therapy is stem cells. Stem cells has its ability to differentiate into different cells is very beneficial. But importantly, it has very important anti-inflammatory benefits. It certainly has immunomodulation benefit. It has positive impact on tissue regeneration. It stimulates wound healing, angiogenesis, and there was an initial case report in 2003 where stem cells was first highlighted, where a patient had very severe peri-anal Crohn's disease, healed within 3 months of injecting stem cells. And in actual fact, there's no trial has demonstrated systemic complications from stem cells. There's no reported systemic infections. The most frequent adverse event was injection at the pain site. And the landmark trial that was now published in 2016 in the Lancet was the Admire trial, where it had shown that compared to the control arm at week 24 and at week 52, that stem cells was certainly beneficial. And these were pretty much patients that was refractory to biologics. These are patients that were severely suffering. And I think recently at SAGES, they also had spoken about this particular trial. Unfortunately, the cost with stem cells is severely limiting for us. I'm not sure if anyone in this country has benefited from stem cells Also, the transportation of stem cells, once it's harvested, pretty much very soon it has to be inserted. For many of our patients with severe and progressive and refractory disease, they have to be considered diversion and ultimately a proctectomy, where 20% of patients may benefit from ostomy, whether it's an ileostomy or colostomy. And it's been shown that by diverting the fecal stream improves the fistulizing disease. The issue really is that once they restore continuity, the surgeons to do that, often the fistulas just come right back. And in 20% of patients up till now, there's associated with the proctectomy. So in conclusion, peri-anal Crohn's disease is a severe phenotype of Crohn's disease. At least peri-anal fistulas, a severe phenotype. It is associated with significant morbidity and impact on quality of life. As I've shown, this is a very difficult to treat condition with and a multidisciplinary approach is required with the gastroenterologists, colorectal surgeons, or the radiologist. Importantly, that sepsis is treated early, is identified early, and the insertion of cetons in patients with complex fistulas, and then the judicious use of imaging, MRI scan, as well as if we have access to having endoscopic ultrasound to show the peri-anal anatomy and then to guide the response to treatment and pick up sepsis along the way. And importantly, the early usage of anti-TNF for complex fistulas, that is the case in most of our patients. And as I've indicated, more recently, data is emerging for patients that are refractory to anti-TNF, the role of vedolizumab, as well as stem cells. Those stem cells may not be practical in our setting. Thank you very much.
Nasief, I'm sorry, Jill hasn't been able to connect. She apologizes.
Okay.
So we're on our own. I see there is a question in the chat. Otherwise, it might be easiest if people just raise their hand and unmute and have discussion amongst yourselves.
Yeah, thanks. I know I spoke to Jill this afternoon. I took her through the presentation. She was happy with what I was presenting this evening. And chatting to our colorectal surgeons at Groote Schuur, this is a very difficult condition to manage. And I tried to do justice by just showing the complexity as to how we should approach these patients. Thank you very much for that comment. And the question is, what are the risk factors for the squamous cell cancer of the anal canal, and what are the methods of screening? So the risk factors are, the longer the disease is present with any other patients, if patients have active disease, if they have active peri-anal disease and they have proctitis, the longer the duration is there, the longer the inflammation is not controlled, as with luminal disease, the higher the risk of patients developing anal cancer. And like I said, the only real indication to do a biopsy is peri-anal biopsies if you think someone has anal cancer. The methods of screening would be, so in the absence of sepsis, it would be like any other patient doing, if the patient has isolated peri-anal Crohn's disease, is doing regular, whether it is flexible sigmoidoscopies, whether it would be a colonoscopy if there is luminal disease. So regular imaging, regular visualization of the anal canal, as well as the rectum, would be important in the context of these patients. I now presented quite a bit of information. Are there any other questions or anything else that that you guys would like me to cover again?
The presentation will be put onto the website as usual, and the video recording onto YouTube. But now's your chance, guys. Have some discussion amongst yourselves. Don't make it harder, Nasief, now.
Yeah, thanks, Sean. I appreciate it. I mean, we have a few of these patients at Groote Schuur, and what I can tell you is that the impact on the quality of life, it's dramatic. And from that one slide I've shown is that to probably the best prevention of peri-anal disease is the early usage of biologics, especially anti-TNF. That's probably the best way to prevent it. And I think that was highlighted by that early slide that I showed. I'll just share it again. Where they have shown that right on top. I'm going to stop sharing. Just want to go to my presentation. Yeah, that one. Can you see this? So I think this is important to. What's happening now? Can you see my slide?
We can see it.
I just want to show that this recent data had shown that treating Crohn's early with a biologic, this one over here on the right hand side, compared to the top solid graph was from the 90s, and it's shown that the rate of pericardial Crohn's is certainly diminishing through the early treatment of biologics to treat luminal Crohn's disease. All right. Any data shown on small molecules? Not yet shown. That hasn't come up in the literature yet. But I suspect that in the near future we will be seeing small molecules. I was looking for that, I couldn't find anything. So yeah, so MRE, any role for MRE as a method to follow a patient? Yes, definitely. I think I'll show that again. You perhaps may have missed it, and I know I presented a lot of information. So MRE has been shown to, doing serial MRE over time has been shown to be an important diagnostic modality in the follow-up and management of these patients. This one over here. I'm just going to share my slide again. There we go. So this particular 59 patients that had peri-anal Crohn's disease, they had MRIs at baseline. Patients were followed up almost over a year, and MRI had shown significant benefits in terms of improving management of patients in the short to medium term. It was only a 1 year follow-up, but certainly over time, there was benefits. The slide I just said was the initial management of fistulas. I think the important part of the MRI was that often if the surgeon misses the fistula in the EUA, the MRI was always right, which is why when we manage these patients, we've taken a history, we've examined the patient's gone for the EUA to drain the abscess, place setons. Those patients should still be booked for the MRI scan. The MRI scan to identify, to define the peri-anal anatomy. And if the surgeon missed the fistula, every single time, 100% of the time, the MRI picked up the fistula. Thanks, Innocent. All right. Karen, I think that's it. We've been going on for almost an hour. My voice certainly is going. I must thank everybody for your time. I know that I had taken you through a whirlwind of information. I have forwarded the presentation to Karen, so it will be available on the Castor Foundation website. And yeah, I just once again, I think we will probably conclude now, Karen.
Yes, thank you very much, Nasief.
Yeah.
I'd just like to advertise the next session when you're ready.
Yeah, I just want to once again thank on behalf of Professor Watermeyer, thank Project Echo for availing us with this opportunity and the Zoom platform to be able to have this educational sessions. I have to thank the Castor Foundation and the various consultants, especially Professor Watermeyer, for allowing us this opportunity to provide this this particular the education. And once again, thanks to our colleagues from around the country for joining us this evening. and also any other colleagues from any other part outside South Africa. I don't have the thing to read from, but that's what I think I should be saying.
You've
Thanks
done
very much,
very
colleagues.
well, thank you.
Thanks, Karen.
Just to advertise the next session, 2 weeks' time, 30th of October. And the topic is post-operative recurrence in Crohn's disease. And Aslam Parker from Tygerberg Hospital will be presenting for us.
All right. Thank you very much, everybody. Have a
So thank
wonderful
you
evening
again.
further.
Thanks,
Okay,
everybody.
thanks.
Bye.
Bye.